Good evening, friends. Today we talk about a topic which is very useful for our clinical practice. Basically, it's a game changer which has come in the last few years for patients with atrial fibrillation on how to prevent strokes by using NOACs. So the molecule which we've giving for our patient AF is or vitamin-dependent anticoagulants. NOACs are non-vitamin K-dependent oral anticoagulants or newer oral anticoagulants. Over the last few years, have tried and tested vis-a-vis warfarin in patients with AF. So they've been tested and found to be successful in reducing risk of stroke and having an almost same, rather less risk bleeding, which is our major complication for oral anticoagulation. So we're going different clinical scenarios. The first scenario is any patient with coronary artery disease who's already on antiplatelet therapy. If oral anticoagulants, obviously the risk of bleeding goes higher. So NOAC-based dual therapy means one antiplatelet plus NOAC versus warfarin-based triple therapy, that's antiplatelets plus warfarin, obviously is safer because the risk of bleeding is less because the number of blood thinners are less NOAC. So patients with AF who undergo an angioplasty or develop an acute coronary syndrome, NOAC-based therapy reduces bleeding outcomes, including fatal bleeding without significantly increasing the ischemic outcome. So we're safe in terms of ischemic events because it's a post-angioplasty or an acute coronary event patient. On the other hand, risk of bleeding is less. So we're very scared about renal failure patients. Is it safe in renal failure, or warfarin better, or are NOACs better? So the impact function on efficacy and safety of newer oral anticoagulant agents. With patients with mild renal insufficiency, NOACs are associated with significantly lower risks of stroke. Low bleeding are significantly observed in NOAC group, so less stroke and less bleeding. So with mild renal failure, it's a very safe bet. Warfarin is a question use NOACs. In patients with moderate renal impairment, there are similar risks of stroke or major bleeding. But NOAC showed a less toxic effect. So, though this is not very statistically significant, but the point taken is with renal failure, especially with NOACs are better than independent or warfarin oral anticoagulant. So NOACs may have potentiality to be at least as warfarin and may equal safety outcomes in AF patients with renal impairment. Renal decline during therapeutics may be likely happening in NOAC arms. So it's nephrotoxic and good efficacy and safety outcomes in scenarios. So in patients in the real world in which we use less or lower dose NOACs versus warfarin. So lower, just an introduction, what are the NOACs in the market here in India? Dabigatran, Rivaroxaban, and Apixaban. So these are the NOACs which are freely available in the Indian market. Compared with warfarin use of reduced NOACs is associated with reduced risk of stroke, major bleeding, intracranial bleeding, and gastrointestinal bleeding. So you just decrease this arbitrarily. It has to be a clinical decision looking at the risk profile and the risk of bleeding in your patients. So dabigatran at 150, you can give 110 bleeding if you think the risk of bleeding is higher. It will still protect against stroke, but the risk of bleeding will be much lower. Current published data suggests that use of used dose NOACs is non-inferior. That's equivalent to warfarin in TF, especially in our Asian population. So NOAC trials compared with warfarin. NOACs is associated with a reduced risk of stroke, all-cause death, major bleeding, and intracranial bleeding. So we're talking about reduced dose here. We're talking in the Asian population with AF, NOAC versus warfarin, which is better. So NOAC trials compare warfarin. The NOACs are associated with reduced risk of stroke, reduced risk of all-cause death, and reduced risk of all-cause or major bleeding. So it wins the battle. It's on, hands down, and you can easily prescribe NOACs. Our main issue in our Indian population is the cost factor, but with the data in the generic version, I think we can do our patients a lot of good with excessive accessibility to our patients at a much reduced cost. One thing we don't realize in patients, we think that the warfarin is a cheap molecule, but the patient has to get a PT-INR done every few weeks. That's the cost. For PT-INR, he will have to come to the hospital. That adds to the cost, and obviously the risk of bleeding is much higher, and that adds to the cost and the morbidity and mortality. So it does not matter the time and the dose of NOAC versus warfarin in Asian population. Risk of stroke, MI, all-cause death, major bleeding, GI bleeding, and intracranial bleeding. So NOAC wins the battle easily. So the clinical outcomes for antibiotic strategy for patients with AF after coronarioplasty. So like I said earlier, NOAC plus T2Y12 inhibitor like clopidogrel ranks first with reduced major bleeding compared with key antagonist plus dual antiplatelet therapy. But there is no significant difference with the therapy plus a single antiplatelet. NOAC plus a single antiplatelet and warfarin plus single antiplatelets almost comparable. But obviously, if you compare warfarin and double antiplatelet, the risk of bleeding goes much higher in the warfarin. Some might say this is a fair comparison, rightfully so. So, in AF patients undergoing PCI, NOACs a P2 inhibitor and VK plus a clopidogrel, VK plus aspirin were associated with reduced major bleeding compared to VK-based triple therapy. So NOAC plus clopidogrel and VK plus is similar. However, the risk of the recurrent panel cost and all that thing that is there. But if you want to be safe, if you want to be not about PT-INR, don't want to call the patient to the hospital a number of times, so NOAC plus a single antiplatelet therapy is enough for a patient post angioplasty. So here, a very interesting part. The NOAC plus clopidogrel, the risk of bleeding keeps going lower. Warfarin plus dual antiplatelet, obviously the risk of bleeding is high. Plus single antiplatelet, in the end, the risk of bleeding is equivalent to NOAC. Initially, there's a surge in the bleeding scenario or the bleeding risk with VK plus a single antiplatelet. So NOAC plus single antiplatelet wins the battle in the clinical scenario, and in the recommendations, we still say that NOACs should not be used in the heart disease. However, in patients with TAVI, that's undergo a transcatheter aortic valve implantation, NOACs have been to have a significantly more protective rate against an embolic event, but no difference in all-cause bleeding or mortality. So the embolic event of stroke may be much lower in patients on NOACs. So for in the valvular heart disease subgroup undergoing a aortic valve replacement cutaneously, NOACs are pretty good. So this is just valvular heart disease. Okay. This is again patients who undergo AF ablation and who are on peri-procedural anticoagulation. So all patients with AF are on anticoagulant, and you are subjecting them to an invasive ablation procedure. The usual protocol is we stop the ablation before the invasive. That risk increases the risk of stroke. So there are randomized controlled trials of uninterrupted peri-procedural anticoagulation. The dabigatran typically lower risk of bleeding compared to VKA group. So dabigatran can be continued peri-procedural for AF ablation with a less risk of bleeding. So uninterrupted is as uninterrupted warfarin in patients undergoing an AF ablation. Uninterrupted dabigatran may be safest peri-procedural anticoagulation management. Optimal strategy for peri-procedural anticoagulation still remains to be determined because there are no randomized controlled trials done on this so far. So a few important slides. What are the appropriate doses of NOACs in subgroups with AF? In NOAC naive patients, that means in patients who have never received anticoagulation in the past, standard dose NOAC shows a superior efficacy and safety with lower mortality as compared to warfarin. So if it was not received oral anticoagulation, start NOAC straight away. Received oral anticoagulation, low dose NOAC showed efficacy but reduced risk of major bleeding and had lower all-cause mortality compared to warfarin. Patients with a prior stroke history, low dose NOAC equivalent efficacy but reduced risk of major bleeding and all-cause mortality compared to warfarin. And among patients without history, NOAC was superior to warfarin. So I would say the agreement here is NOACs are better than standard warfarin, but in patients with a clinical decision, if you want to use low dose NOACs, you can use low dose NOACs, which also reduce the risk of strokes. So standard dose NOACs had better efficacy than warfarin in OSC naive patients, and in patients with previous stroke, you give low dose NOACs. And otherwise, standard dose have lower mortality than warfarin in OAC naive patients. This is the these plots for whatever we just said before. So standard dose NOACs should all-cause mortality than warfarin in oral anticoagulation naive patients with AF. So very important line here. And low dose NOACs was better than warfarin among patients with prior stroke history in terms of all-cause mortality. So prior stroke, use low dose NOAC. In patients with OSC naive patient, use a standard dose NOAC. So what about the elderly patients? NOACs have better efficacy and equivalent safety compared to warfarin in elderly patients with AF. So our main concern with elderly patients is bleeding. So for elderly patients, NOACs have shown better efficacy and equivalent safety compared to warfarin, even those in patients moderately impaired renal function. So all-cause mortality was lower with standard NOAC compared to warfarin in the elderly age group. So you can switch to low-dose NOACs to have standard guidelines above the age. Each NOAC has a standard guideline in which you can come to, like apixaban we brought down to 2.5 BD, dabigatran to 110 BD or 75 BD, rivaroxaban to 10 OD or that is your clinical decision, but still lowered risk of stroke in patients with AF. So standard dose NOACs have better efficacy than warfarin in elderly. NOAC reduced major bleeding. They don't sense they have lesser bleeding incidence compared to compared to warfarin in non-elderly patients. They are a comparable safety profile as compared to warfarin in elderly patients. Even with a high GFR, NOAC had a comparable safety to warfarin, and mortality was lower with standard dose in elderly patients compared to warfarin. So I think the time has come for all of us to shift to NOACs with easy monitoring, good compliance, no regular changes in the dose required, improved efficacy, and less bleeding incidence. Thank you very much. Any questions? I'll be very happy to take from this team gathering. How does from VKA to NOACs? It's a very important question. Before I'd like to answer one question. How do you start a NOAC? Suppose the patient is on low heparin. Suppose he's on Xane 60 BD. I want to start him on dabigatran. So if he has received Clexane during the morning, you start Clexane after that. Start the dabigatran 1 hour before the next due dose. I think that is the right way to start. It's very, very clear that we are shifting from warfarin to NOAC. But any patient you want to initiate a NOAC, so miss the dose of low heparin. Just before 1 hour before the due dose, you start with anticoagulation like warfarin. You will not start till the PT-INR knows, because if the patient already anticoagulates, the warfarin dose is something that you cannot predict. You have to check the PT-INR before you shift. So PKAs, we are doing regular PT-INR to see the dose. The patient can be on 10 mg of warfarin or acetylform. Dabigatran, according to creatinine clearance, according to the age, will have a fixed dose. There is no equivalent dose. So the recommendation is not that if the patient is on 4 mg, you start 65. No, it is a fixed dose. You try to start 150 BD for dabigatran for all your patients, except age group or with a higher risk of bleeding, in which you can go to 110 BD. Sometimes there is a recommendation. There is no point giving a OD dose for dabigatran. So, like I said, shifting from VK to NOAC, please do a PTR, let it come to subtherapeutic levels, and start the dabigatran or any NOAC that you want to. Do not give both at the same time. You will have to wait for the therapeutic effect to come down to an INR of at least less than 2 before you start the dabigatran. Thank you, everybody. It was a pleasure. Hope we regularly meet at the ECMEs, and down keeps me occupied as well. I'm sure we can percolate our knowledge and share our experience amongst each other. Thank you very much. Bye.